Okay, we are back. So let's jump right into it. Let's talk about placing the collagen membrane. So the collagen membrane, it's 30 by 40. You take it, you're going to be doing a little bit of carpentry work, so to speak. So you want to know the size of the sinus you're going to fill, and you may have to trim it. And then you cut the four corners. And here it is. So we're trimming the corners, makes it easier to seat it in place. I tried doing it without, and it's a lot easier when you trim the corners. You know? This is the CGF fluid that we take from the patient after we centrifuge it. You see how the handling of the membrane is? Okay. So now this is going to be your superior aspect of your sinus lift. Too big, take it out, trim it again, cut again. You see how the membrane did not disintegrate? You make sure you take it all the way to the back of your sinus there, okay? Now, you want the membrane to be, you don't want it to go all the way to the bottom of the sinus. You want it to be hanging up on the bone as superior as possible. Remember when we talked about bone? The more bone you expose, the more feeding you will have for your graft. So you don't want your membrane to grow. It's basically just you're putting the membrane, you are tacking it to the outside of your window, and then the inside of it, you cannot have it draped down all the way to the floor of the sinus. It's got to be up as much as possible, okay? So it goes all the way to the back of the sinus and it drops down 0.45 millimeters. Now, you can take those PRF membranes and put them on the membrane in the back. They will help stick the membrane to the wall too.
So why is this better than this PRF?
Hmm?
The membrane.
For the top, oh, because the membrane will last a few months. The PRF will disappear very quickly. And you want a solid roof to hold your graft. And we're going to see why going forward here. Dr. Christine.
Yes.
We are back.
Okay.
All right. Just let
You hear me?
Yes.
Oh, okay, okay. I have to mute it.
Okay. We repeat. Memorize the picture. That's exactly what you're going to do. This is every case. That is going to be your sinus lift protocol going forward. Okay? So we're not going to lift, hope for no perforation, and I'm actually going to address that shortly. Okay? You take the membrane, you're adapting it superiorly, and you're letting it drape on the posterior wall of the sinus. You take your PRF and you're putting your PRF where the membrane and the sinus wall meet. And that kind of holds everything in place. Okay?
So you push the membrane inside after you just elevated it?
Yes.
Push it inside and then you put this membrane and then you put the PRF.
Yes. But you want as much bone visible as possible because that is going to feed the graft. Okay. Now, what's happening here? Those tacks that you're going to use to stabilize the membrane in place. If you use the gun, it will bend the tack and you throw it out and get another one. throw it out, get another one. You'll waste 3-4 tacks, okay? Each is $10-15 or so, unnecessary expenditure. So you're making a little trough around your window where you're going to attach your membrane. This way the tack doesn't have to fight the cortical bone, and it goes right through. Are you all okay with that? So around the window, okay, the window edges, you're going to make a little trough. You're going to denude a little bit of the cortical bone. Okay, this way when you put your tack, it goes in through the bone right away. Here we go. 1. And easy. Okay. Last time we did grafting, graft case, I can't remember. We used the tack, okay? And now that membrane is not going anywhere. Right? Use 1 or 2. You want to make a little dimple for the tack, okay? But think about this. You have retraction, you have a membrane, and you think you're without being able to see where you made that little hole. But if you made an area, it's going to be easier for you to get that tack to be secured. Okay? To secure that tack, if you have just a little dimple, you're gonna have to aim for that dimple. Okay? But if you have a tract that you've denuded, then that. And then what if you're moving your membrane right and left or whatever, you got a whole area that you can attach your tack to, okay? And after you put the tack in there, check it. You don't just want to tack it and leave it, okay? Feel it with the back of your, back of the mirror, back of the periosteal elevator. If it's moving, you will see it dancing like that. Take it out and do another one. Don't contend with tags that are not secure in place. Otherwise, your membrane will not be secure. Here you go. 1, 2. You see the sinus? You see the membrane? You see the wings that we cut out, sticking out the window? They are secured in place. Okay?
The first membrane replaced.
That's the first membrane we placed.
And then you have the PRF.
And then we add and then the PRF is inside. Okay? If you cannot take bone, if you cannot take blood and you don't have PRF, it's not a deal breaker. Okay? We're trying to do everything we can to biologically help our graft. Okay? Okay, do you see the edge of the membrane? And do you see the bone beneath it? Can you see it? Okay, the membrane, you see there's bone. It's not covered by the Schneiderian membrane. Okay, this is key. So you're opening the window, you start reflecting, you start raising the membrane, and then you start putting your memlock or the collagen cross-linked membrane. You get the 30 by 40. Sometimes the sinus is too big. The area, let's say it's it's a free end cell of premolars and molars all the way. That 30 by 40 is not going to be enough. You may have to get another membrane, suture them together so you can have a big umbrella over there. Okay. You soak the membrane, you place the membrane in the sinus, and then you tack the membrane. The edges of the membrane on the posterior wall have to leave enough bone exposed to feed the graft. How many times did I say that now? Over 3 times. Okay, that means it's very important. You don't want it to drape down all the way. You don't want it to go down and cover the floor. Hence, the trimming of the membrane. Okay, we want just enough to hold the Schneiderian membrane and to hold our graft, but leave the rest of the bone exposed. Okay, so here's the membrane, the window, and we put the membrane, we stabilize the membrane with a couple of tack screws on the outside. and then you add the bone. Here's the graft material. You see how it looks like a piece of pie that you cut? That's because we added the CGF to it, you know? And when you take the PRF and you put it in the box and you apply pressure, all the fluids that come down, they will help the bone to coagulate. And then you have what they call the sticky bone. The Koreans came up with it first. So we give them credit for that. So you take the bone in chunks and you start packing. Now, how hard do you pack? Where do you pack? You pack the mesial, you pack the distal. What do you pack? Okay, so you're going to take your graft material, you put it in your, if it's loose, you find a lot of it will start dropping to the patient is sitting in a supine position, everything is falling distal. Okay, fill it up, but you must pack your anterior. This area gets missed a lot. Okay, I missed it a lot. Okay, or I got pocket that I couldn't fill. So you want to start filling the mesial and gentle pressure. You don't want to pack too much bone. You don't want to pack a lot of bone because everything is going to expand. Okay, and we'll go over studies that will show the graft material expanding. Hence, how we're going to close the window coming up. Okay. So sinus bone grafting. Whether you put allograft, whether you put xenograft, whether you put full synthetic, okay? I was against synthetic and xenograft because I thought it doesn't go away, it stays for years, and I want all this replaced with bone. Okay, and that sounded like a very rational reason to me. I'd rather have allograft in the area that gets turned over with natural bone. Now, the more allograft you use, everything shrinks more. When you use the xenograft, because it doesn't shrink, it doesn't go away as fast, it holds the volume for you. And believe me, there's enough space in between all the matrix, okay, for natural bone to grow and to increase and to get actually good bone to implant contact, okay? So that's where I had a paradigm shift. When I looked at the others, especially the Europeans and the South Americans, totally just using xenograft, said, well, there must be merit to using xenograft, okay? So here we're lucky to have allo and mix allo and xeno, keep the volume, and then the membrane on top holding everything up, okay? Now, if you can add some bioactive modifiers to your graft, by all means do. What do I mean by bioactive modifiers? Fibrin, the PRF can be part of it, right? Okay. How about bone morphogenic proteins, BMPs, GEM21? Okay, those are things that you can use, and I will discuss them in detail coming up. Particle size. Particle size, remember what particle size we want for our graft? 600 to 100 to 1000, okay? A mix is good, and this allows the bone to go in, okay, and infiltrate. Bone. You can go to Salvin and find this bone harvester. It's a safe harvester. It allows you to harvest bone for up to only 3 millimeters. So if you take a little bone out of the ramus, okay, you numb them, open a little cut, boom, boom, you know, do a little, you know, a couple of holes, scoops, yeah, and then put it and mix it, and this way you have your own autogenous bone to add into the patient's sinus. I think this is gold. If you guys can do that, that is wonderful. Okay, you just have to let the patient know, hey, we're going to have a little opening, we're going to take a little bit of bone here and add it. Sometimes you're opening all the way to the back, and if you're lucky and the patient has tuberosity, you can harvest the bone from the tuberosity and mix it, and you're already there in the area. take the tuberosity bone, mix it, and add it in the area. Okay. So, there are implant drills that are hollow. Have you guys seen them? Have you seen those? Okay, so you can use those too. And if you have a stopper, a 3 mm stopper, okay, get it, like the IBS kit, and get that. Take a piece of bone, couple of spots, and add it. So there are many ways, and there's a lot of bone to be found around the mouth. Okay, and remember when we did the bone grafting lecture, the bone that you get from the head and neck is far superior to bone that you get from the tibia or any other or iliac crest. Okay, and those two doctors from Madrid, Spain, I shared their slides and their studies. They've done it over 10 years. Okay, bone that is taken from other areas of the body, actually other 80% of it goes away in 6 years. Okay, so if we have a gold mine, we're working around the gold mine, use the gold mine that you have around the have around the. Okay. Okay, so we're doing the allogenic bone, we're doing the xenograft, we can do the autogenous bone from the tuberosity or bone shavings, and we're having the bioactive modifiers, the PRF. All these things will help our bone growth in the sinus, in the grafted sinus, to grow. Okay, the more the pneumatized, the more the sinus is pneumatized, the more we're going to need. The more volume we're going to need, the more blood supply we're going to demand on the body to supply the graft. Okay, the more we're going to window we're going to open. So the longer the span, the more the work, the longer the heal. Okay, the more demand that's going to be on the patient's body. So we start filling. Don't forget the anterior wall, your mesial pocket must be filled. Fill it, and you apply pressure, not a lot. Just make sure, like how you pack composite. Can you pack composite like you pack amalgam? You can't. Okay, so you know how you pack composite. It's pretty much that feel. You pack bone, but not too hard. You're okay. And then you can take another PRF. Now we're going to close the window. If you're not going to put the bony window back, okay, there's going to be expansion of the wound, right? There's inflammation. With inflammation comes swelling, expansion, okay? And actually, I'm going to show you a study right now. It shows that in 100% of cases, the graft that we place in the sinus gets expanded, okay? There's some kind of expansion. So we're going to put another membrane, and we're going to tack the second membrane to hold things down. We're going to put a lid on it, and we're going to seal that lid. We're going to make sure it doesn't move, okay? Underneath, over it, if you want to put another PRF, it's mostly for soft tissue healing. Go ahead. Okay. See, this is a study. It's 132 sites, and I'm going to share. We want to know if the post-operative swelling of the maxillary sinus membrane occurred after sinus augmentation. And here is the case. Swelling of maxillary sinus membrane occurred in 132 sites. So they took 132 subjects, they tested for swelling, and it happened in 100% of the cases. So you can pretty much count on, if you don't close that window, there's going to be some expansion. And if you are not really tight in how you closed everything, things are going to get out of whack. You're going to get wound dehiscence, wound opening. And you might remember we were talking about bone graft. Remember micro movement? Okay. Micro movement. Is it good for bone healing? It's not good for bone healing. So we want to prevent micro movement as well, as much as we can. We're not going to achieve it 100%, but we do what we can. Okay. So we pack the bone, not so tightly, and we close the window tightly, and then we close our suture now. This is an important aspect of things. Now you close the window, you added a membrane, okay, and you added PRF, and you want primary closure, okay? Do you think your tissues are going to go back in without any resistance? There's going to be resistance. So what do? You release the tissues, okay? If you're going to do any kind of horizontal bone augmentation, okay, then you want to do blunt dissection using your hemostat, opening the buccinator muscle in that area too. I'll show you. Okay, flap closure. I'm going to talk here. First one is your mesial one, always. Your first suture is going to be your mesial suture. What kind of suture are we doing? Huh? Vertical mattress, okay? So the base of the papilla, buccal, lingual, coming back, lingual, buccal. And you want to come out about 3 millimeters below the tip of the papilla, and you tighten it, and that pulls everything back into place again. And then you close that. Why are we doing the mesial first? Yeah, and that's the aesthetic zone, right? We're closer to the aesthetic zone. If it's open in the back, I can put PRF, I can do something and close it. But what matters to me is the front. Okay. So we're closing the papilla in the front, first thing. Buccal, lingual buccal, okay, vertical mattress. Here we are. And discussing how we tighten it. And then the releasing incision also gets closed. And once you close the releasing incision, then you can go back and close the rest. Okay. When do you see the patient? I want to see the patient 1 week, 2 weeks. Matter of fact, I try and bring them, 1 week, 1 week, 1 week, 1 week for a month. I just want to make sure that the first month, everything. You can still get some complication after 2 months, but if I'm past the 1 month, I think we're okay. We're okay. Okay. Within 4 to 10 months, usually if it's a big sinus lift, what I do is I wait 6 months, bring them back, do a CT, and then decide what we're going to do. I'm going to fly through this. I think Dr. Andy and Dr. Lee did this case. We did a membrane. We didn't do any tag superiorly. Here's the PRF that we placed. And then we packed the bone. This was strictly PRF. We might have added a little bit of the pack, and here's our window back. Okay, and here's our closure. And here's the lift. Okay, now let's talk about one stage. The previous slides we're talking about 2 stage. I open, I graft, I leave, I come back. Now, can we actually do a lateral window and do immediate implant placement? Yes, if we have the vertical and the horizontal bone. You have vertical and horizontal bone, you can do the sinus lift and you can do the implant. And in here, I'm going to talk about Versa. Who's not familiar with Versa? We're all familiar with Versa. Very good. So I can fly through this very quickly. Versa, pushes the bone, condenses the bone laterally and apically. And actually, if I'm going to do a sinus lift with immediate implant placement, I don't use the drills. I use the drills maybe in 10-20% of the cases. I use Versa 80 to 100% of some cases, only Versa. Okay, so if I'm doing a lateral window and I'm placing implants and I know I have 5 millimeters of bone and I can't get quite the lift I want using Crestal, so I'm going to do lateral, but I'm still going to do my osteotomy using Versa. Okay, what Versa is doing, it's compacting the bone and it's actually causing good initial stability. So this makes me less worried about the implant going flying in the sinus. Okay, so here we are. We're opening the window outline. We're using the number 8 round burr. Here we are using the piezo, removing the window, and then we're doing the membrane elevation. Remember, we start with the superior, mesial, distal, go down to the inferior. The inferior wall is about 3 millimeters above the alveolar ridge, okay? And then we are lifting the membrane, okay? Make sure that you lift the membrane enough all the way to the posterior wall. And now we are getting our collagen membrane. We are cutting our collagen membrane and we are attaching it. On the outside of the window, we're doing a little trough, okay? So we can tag the membrane easily, put 1 or 2, not 1 or 2, I mean put 2 or 3, okay, to secure the membrane and start your osteotomy, okay? You all know how to use the Versa, okay? You can actually use it as a cutting tool. And so the initial is always forward, so you're cutting, and then you're doing the rest in reverse, and you're undersizing. So if we're placing a 4.0 implant here, I'm probably stopping at somewhere between 3.3 and 3.5, okay? Maybe 3. It depends on the bone, okay? So you undersize your osteotomy, okay? And the reason why I'm only comfortable with 5 millimeters of crestal bone is because what do we do for our implants? We sink them. We sink the implants. We don't leave it at the bone level. We go a millimeter or 2, okay? So that's going to eat in your stability, okay? Now we've opened the window. We're packing the bone. Let's pack the bone. Don't forget the anterior area, posterior area, push all the way back, okay? And you pack as much bone as you can, okay? And now you start placing the implants. After you place the implants, you pack a little bit more bone. If you don't have the window to put back on the bony window, then you put the membrane, tag the membrane down. And if you placed implants, you can actually pierce the membrane and have the membrane secured on the crest with the cover screw or the healing abutment, and on the top with the tag that you place. So this way the membrane doesn't move. Do you get the idea here? You see the membrane and the cover screws of the implant are going through it like a poncho, yeah, through the membrane into the implant. So the membrane is secured on the palatal aspect or the crestal aspect, and superiorly we're using the tags to secure the membrane. This is very good, as this is all we can do really, okay? We always do this whenever we place an implant. We always take Ostel readings. Okay, those are some very good numbers. Those are numbers, but those numbers will change. Usually within the first 2 to 4 weeks is when you get an area of osteoclastic activity around the implant. The implant actually gets a little loose, okay? And then it goes back. So that is only telling me that it's okay. The implant is not floating. There's good bone contact initially. all right? But when it's time to expose the implant or to take the impression, those number may vary a little bit, okay? Closure, close it up really well, restore, we're good to go, okay? Okay. Let's go through another case, okay? Let's go through another case. Incision design and flap management. We want to see where our anterior window is going to be, and then our anterior incision is going, is going to match that, go far as much as possible, raise a big flap, raise it, use the gauze to push everything up. You see how the area is nice and clean, okay? If you take some gauze and add some anesthetic to it, lidocaine with epinephrine, okay? As you're reflecting, the epinephrine is going to help you with some of that bleeding, okay? Having the element also helps quite a bit. Incision, now we go to our window. We have formula, we know where we're going to open, right? We know where our anterior cut is, where our posterior cut, 8 to 10 millimeters going upwards. We do our cut, we take our window, we do the elevation, and we start cleaning the window. We don't want any sharp ends in there, okay? We elevated the membrane. Now we get the collagen membrane cross-linked. We start shaping it, we cut the corners, and then we put it in, and we start with the implant osteotomy. Okay, you do the implant osteotomy. You do your osteotomies to match your implant that you're going to place. You know this at the time of surgery or ahead of surgery? Ahead. We know what we're placing, okay? So we know we have so much horizontal bone, we have 8, 10, 12, we know we're placing 4, 4, 5, or 5, okay? You do your osteotomy. If the bone is very cancellous, we're going to under prep. If it's medium, then we know we're not going to have to stress the bone that much, okay? We do our osteotomies, we pack the bone, okay? Place the implants, pack more bone, and then attach the membrane, and here are some of the numbers again. This was actually very good, very good initial stability. So we attached the healing abutment. In this case, you start closing your incision. First, what goes back first? The papilla. Papilla goes back first. We're using the vertical mattress, okay? Base of the papilla, buccal lingual, lingual buccal, tie it a couple of times, okay? Stay in place, close the releasing incision, and then we start doing either interrupted or mattress, sutures, whatever you can. Now, if you've increased the width at all, then you want to do release. So you release the periosteum, so you can pull that membrane, you can pull the tissues, and everything is closing nicely and passively, okay? If it's not passive, it can open, and this can be one of the complications as well, okay? And here we are, here's the bone, here's the restoration. You look at this restoration, and I know it's easy to criticize it, okay? It's edge to edge, okay? I don't like, but where were we? What did we have before that? Okay. And maybe the implant should have been angled out a little bit more when it was placed. Okay. In hindsight, you know what they say, hindsight is always 20/20. Okay. But in hindsight, otherwise, if you want to overcome that edge to edge bite, you're going to cantilever your implant, but your crown buccally too much. So I think edge to edge is fine. It's not in the smile line. The patient has got 90% of their function. We're good. Yes, of course.
If you do immediate with the lateral window,
Yes.
do you not want to cover it? we put in the heating about, that was the previous, right there.
Yes,
If you have
we look
any-
at those numbers.
Okay.
So if our cells are giving me, when in a sinus lift, if it's 65 and higher, I'm putting healing
With
abutments
the
on with the sinus lift. If I get 60 or lower, I'm covering and I'm closing.
And same, guidelines you go with as far as not connecting with implant restorations on the maxilla.
Not just that,
Hmm.
it also depends on the patient's occlusion,
Mhm.
okay? Is it,
Let's say this
it's
patient-
like a 70-year-old lady with a smaller frame, okay? Or we're talking about like a 55-year-old big guy who's, working out in the yard still, okay? For him, I definitely split. For her, not necessary. Okay, so it's a judgment then. Good questions. Okay. Here's the lift. Here's the sinus. It's not going anywhere. Good, nice, even bone. Okay. All right. Now let's talk about the bioactive modifiers. Are we clear on what's passed? Are we okay? Okay. We're on slide 236. We have to 900, so we got a few to go.
So you're releasing the membrane on the superior,
Yes?
just barely releasing it to be able to touch the membrane. You don't want to go like superior to the superior bottom of the wheel.
The Schneiderian membrane itself. No, we don't want that. No, we don't want to.
It goes
Yeah.
to just-
Yes. Yes.
Dr. Carmi,
Yes.
wouldn't it be better to put a healing abutment, healing screw, so that it prevents it from sliding into the sinus? It just kind of prevent that
Yes.
and
Like
cover
here.
screw.
Like here.
Yeah, yeah. What I mean is, what if it's less than 60? I would still think that if I put a a healing abutment, then the chance of it's, slipping
Going
into
in the
sinus is
yeah.
less.
But and then you want to use one that has very low
Wide
general
diameter.
height but wide.
Yeah,
So
yeah,
you
yeah.
use one that's 2 millimeter high but 6 millimeter wide or so.
Yeah, yeah.
To,
And then the
so it
second
doesn't
question-
slide in the hole. Yeah.
second question, Dr. Carmi, can you show us, me again, the tap that you do for the membrane before you put the bone in? So
The
you're going to put titanium tack onto the membrane, the collagen membrane?
Here, this one. This one right here.
Yeah.
Okay, yeah. So you see how the membrane is cut at the corners,
Uh-huh.
and then the edges come out, and then we make a little trough around the window to put the tacks in.
Okay.
Okay, and here's the
It's so hard to see even on Zoom.
yeah.
Even my glasses, it's hard to see.
You don't have a
Yeah, you can ask them to come here and I will teach you.
yeah.
Maybe because I'm
Can-
I'm getting a suntan in the
Can you
same
see?
time.
Can you see this one?
Okay, yeah.
Okay, and once you get the email, it will have everything. You can blow those pictures up.
Okay.
Okay,
Yeah, yeah. Okay. Thank you. I'm sorry.
you're welcome. No, it's all right. Okay. Bioactive materials. Bioactive modifiers. You all know them. When to use, when not to use, what to use. How much do they cost? Okay, that's a big question. Okay. So Dr. Picos has been using PRP for a long time, and then PRGF, and then LPR. Talked to Dr. Shakrun and Dr. Myron down in Florida. And actually Dr. Picos, they came up with a book that has everything to do with PRF. Okay. If you guys are chemistry nuts, you can go for it, but it will tell you what each one is and how to prep it and what it does and all that. For our purposes, the LPRF that we do, okay, is good for soft tissues, okay? And we use the fluid that comes out that coagulates to mix with the bone that makes a sticky bone, and then it's easier handling that we can pack in. There are cases when I cannot take the blood out of the patient, and then I have to proceed without. Okay. So PRF in terms of bioactive modifiers is probably the lowest one in the rung. Okay. It doesn't really help with any kind of bone formation. Okay. That was way back then when everybody thought, maybe 12 years ago, you know, and when it was a big fad, everybody thought it's going to, you know, like you put the PRF and it's going to make the bone and all that. And after the years have gone by, it only helps with soft tissue, pretty much. Okay. If you take out a tooth, number 19, for instance, and you pack it with bone, you still have an open wound. You take a PRF, you put it on top, and you do a little figure 8 and leave it. And within hours, it will seem as if the tissue has grown. So it really, really helps, and it's very useful in wound closure. Okay, so you can instead of doing a CGF right away, you know, CTG, connective tissue graft right away, you know, you can add the PRF, and that will increase the tissue thickness somehow. Okay, but don't count on it in terms of bone growth. And it is not long lasting. It's 7, 10, 14 days maybe. Okay. So plugging a hole in the sinus membrane, I do it, but I always use a membrane, and I can put a PRF over it, but I always use a membrane. Membrane will last long. PRF will not last as long. Okay. You take the blood, okay, you centrifuge the blood, okay, and that's what you get. All those fibrins and the cytokines that are released, they're in that little clotty thing that looks like a slug. You take it and you put it in the wound, and there's a concentration of good cells in the area. Okay? It helps? Absolutely. Is it absolutely necessary? No. Okay. Leukocytes. It does have a lot of leukocytes, and it does help a lot, okay, with the wound healing and fighting any kind of bacteria that's in the area too. Does it help? Yes, it does. Does it help with formation of new blood vessels in the area or venules? Yes, okay. So mostly for soft tissue, mostly for wound healing, but count on it ultimately? No. Okay. So transforming growth factors, platelet derives from growth factors, vascular endothelial growth in the area, also important coagulative process. So that's what it does. It's all good. Now, let me warn you, okay? And after a while, it may turn white and it may have a bad smell, and the patient will complain about that. It's like, this thing turned, have you ever had that? Anybody? Andy? No? Sometimes it turns white and it becomes like a necrotic tissue. Okay. So if the patient says, hey, I have a bad smell in my mouth, see them right away. It's usually maybe the PRF, okay? Maybe something else is going on, but it does have that tendency sometimes to cause a bad odor in the mouth. So I'm just letting you know, okay? So there's a downside to it, okay? For those of you who are chemistry nuts, and what the leukocytes that are in the PRF produce, interleukins and tissue, and things to help with the tissue necrosis and healing. Okay. So you can see what you see this all the time. We take it, we mix it with our bone, and we get our sticky bone mix. Okay, I went overboard with the stuff about PRF if you guys want to. So let's get to the practical. You draw the blood, you spin the blood, you express the clot. Okay, and then you take it and you attach it. You're going to need those tubes. You're going to need red tubes. You're going to need yellow tubes. The yellow tubes are glass. They have EDTA in them. The blood doesn't coagulate when it goes through the centrifuge. Okay. You're going to need that little thing, the press thing. You put the PRF on the top, put the metal over it. It bleeds underneath. It has a little plate underneath. It collects. That's where you put the bone, and that's where you get the sticky bone. Okay, you're going to need the butterfly needles, gauges 21 and 23. 21 for most of the cases, 23 when the vein is smaller. Okay, and the little plastic tube that holds the red or the yellow tube. I'll show you where to buy everything and all that. Take the blood, okay, it has to be equal. So when you put it in the centrifuge, it has to be symmetric. Okay. And you spin it, you take it out, you cut it, you got the fibrin. It comes out of the tube, you cut, you leave the red part behind, you take the part that looks like the slug, you put it on there, and here we are. And the bone underneath, and you get your sticky bone. So that's the PRF. And then you close your soft tissues and everything is hunky-dory. You can use it for extraction site grafting. Okay, you can use it when you do immediate implants with rich augmentation. When you do immediate implant, let's say it's a molar, you take the tooth out, you do your osteotomy, you put the implant, you pack bone in the mesial, distal, or palatal, or whatever. You take your PRF, you put it on top. Okay. You can take your healing abutment and punch it through the PRF, engage it into the implant. Now you have an implant with a healing abutment on it and a poncho of PRF on the outside. And then you can take like a figure-8 suture, and the patient comes back, and the healing looks really, really, really fantastic. Okay, it is not for ridge grafting. It is not going to add any bone. It is not going to directly impact the quality or the quantity of bone, okay? It all has to do with soft tissue healing, okay? Now, I think this is a video. Is this a video? All right. Recombinant proteins. What is the word recombinant? What does it mean? Made in a lab, okay? Lab-made proteins. There are two main ones I want to hone in on, okay? BMPs, okay, bone, and GEM21, right? One is more expensive than the other. Let me start with the less expensive, GEM21. Lynch Biologics, actually now Geistlich bought it, okay? So now you can get GEM21 through Geistlich. So it is a good product, okay? It works. And it comes with the liquid and some bone. It's usually refrigerated. You take it out, you mix it with your bone, and you let it sit for 15 to 20 minutes to activate it. It takes 15, 20 minutes once you mix it to activate. and then you can take it and you can add it inside. What it does is it enhances the body, maybe 100 to 10 to 100 times to get more cells into the area. So what it's doing, it's getting in more osteoblasts and more endothelial cells into the area, so it enhances the healing. And remember, if you're doing, when we get to the lecture and we're talking about peri-implantitis, GEM21 plays a big part in the healing, and the studies show a lot of that as well, okay? The product contains 1,000 times higher concentration of rhesus PDGF, okay? These are all the cells that you need to come and reconstitute new bone in the area and tissues, okay? You mix that with the bone, with the allograft, and you're going to get periodontal regeneration. You're going to get bony regeneration. If you're doing a large sinus, okay, and you want to give the patient a leg up, add 1 or 2 GEM21 in the area, and it will help, definitely help. Okay. Now I want to talk about BMPs. BMPs are very expensive, okay? But it's almost like the silver bullet, okay? It gets the job done. For about 1 cc, you make roughly, I don't know, maybe $600 to $1,000, $900 or so per cc. It's expensive, okay? But it's expensive for a reason, okay? It's expensive for a reason. It actually causes new bone to be formed. So in an area where you don't have any bone, it will actually really jumpstart the process, okay? So if you're in doubt at all, if you really want your patient, it's like once, we can only do this once, and we really have to get this through, okay? Get the BMPs, okay? How do they work? How does it work? Okay. It helps, it brings all of these together, okay? This is what BMP does, okay? Tissue scaffolding, and then it also has signaling molecules, so it brings in osteoblasts into the area and osteogenic cells. So it will call all the endothelial and osteoblastic cells to come to the area. You got bone, you got blood, okay, and these are very, very powerful chemicals. Be careful of what you ask for, though, because it will cause a lot of inflammation. It will cause a lot of inflammation. The patient will actually swell, okay? There will be edema, there will be swelling, it will look like it was a very, very bad fight, okay? So if you use it, you have to let them know. And actually, it can regenerate bone de novo, brand new bone. It's like you got something from outside, dropped it in a medium, and boom, bone came about. Okay, it's that powerful. Okay, what it's doing, it's bringing all the extra cells from around the body into the area, and it comes in that format. Okay, it's a fluid, and there's a membrane. So you mix the fluid, it's powder and liquid, you mix it. Now you've activated it. There's your $1,000. And then you add it to the membrane. Okay. And if you have a large area, you cut the membrane and you mix it in the bone and just disperse it all over. Okay. So here it is. Here's the sterile water and the powder, and then it has a collagen sponge. It's like that little collagen membrane, this little piece. And once you mix it, you add it, okay? And you wait for it. You cut it into pieces, and then you mix it with your bone. Okay, you're gonna do xenograft and allograft, whatever it is. Just mix as much bone as you can and disperse this as much as you can, and go ahead and put it in your sinus. BMPs, they're biocompatible, easy to handle. They resorb with new bone formation, and the collagen sponge is actually binding the BMPs to it, and it's doing what's called time release. So it's not going to be all done in one day. It's going to, that collagen sponge is going to slowly release that into the meat. So there's constant calling of those tissues.
Does it come with the collagen itself?
Yes, comes the whole thing comes together. As a matter of fact, here's your next question.
You guys are using it tomorrow?
There it is. No. No, we don't have a case that requires that tomorrow. Okay.
He asked me to come to the outfit to work on Monday after we finish the lecture.
Uh,
Not tomorrow, but Monday.
Okay.
I just left for me.
Okay. Okay, here we go. You can get the BMP, you can get the small, it'll give you 1 or 2 or 4 or 6 or a big piece. And I think you can go up to $3,000 or $4,000 if you get the big package. Okay, I know I can't charge that to my patients.
Have you used this in periodontitis?
BMP?
Yeah.
No, but Gem 21, yes, but not BMP.
Does it work?
Yes,
How many
if
million
you
is
do it correctly. Sometimes you don't get bone when you do peri-implantitis. If you clean the surface well, okay, you get regeneration of soft tissue and then especially on the buccal, and you will get nice good tissues. Maybe on the mesial or the distal you can get bone to grow. Okay, but it takes a year and a half to see the full result. Yeah. Okay. Who's a chemistry nut here? Nobody? Good. That's why we're dentists. Okay. Okay. It binds to stem cells and then it proliferates, and then it actually, you know what a stem cell is? It's a teenager who doesn't know what they want to do with their life. Okay. They have no clue. They want to be, like a TikTok star. They want to be a bus driver or a surgeon or whatever. You never know, right?
Nowadays,
So- There you go. Yeah. Yeah, that's right. I'm a little behind the ball here. But that's a stem cell. The BMP helps them to differentiate into bone. That's it. They're not. You bring the stem cell, it can turn into anything. The BMP actually helps it turn into bone. Okay, that's a very, very good. So if you need it, get it. All right. Let's move on. The material is called infused sometimes. If you want to buy it, it's called infused. Okay. How many times you get somebody to knock on your door, says, "Hey, I got a new implant." What do you ask them? Is it FDA approved, right? Do you know that it's not illegal to use non-FDA approved stuff? Okay, it's not. But you have to inform your patient, and you have to be ready if any thing happens, right? So you buy an implant off of eBay, okay? You place it in the patient's mouth, it fails. You do it again, it fails. You do it again, patient sues you. Now you're sitting in a deposition, okay? You didn't do anything wrong, okay? But were you able to safely do the procedure using what you used? Okay. Now, if you bought a brand name, whatever FDA approved, okay, and it fails twice and the patient sues you, And the lawyer says, hey, and they're like, you know what? I got this big company right here. You pull up the website, it's got the FDA, they've got the full 501c or 501k or 510k or whatever the FDA approval is. Here it is, you know, and here are the now you're not defending the implant, okay? Same thing with the bone graft. There's off-label stuff that you can get, okay? It's a lot less expensive. But what kind of experience do you have if things were to go awry? Okay. You get BMP, they get inflammation. It doesn't go away for a couple of weeks. Okay. They got huge edema. Have you done anything wrong? You bought an FDA approved product, you discussed with them, they had an overreaction. Can you control it? No, you didn't do anything wrong. And the product is backed by FDA. Okay. I'm not saying that every FDA product is actually a good product. I'm just saying you got the legal cover. All right. So if you find things off label, it's not illegal to use. Okay. If I find something that's off label, that's actually legal, that's being used in Europe all the time, I personally will have more confidence in using it, than not that I do, but that's how my thinking goes. Okay. This slide up here, titanium mesh. I stopped using it. I admit I'm a failure. I can't make it work. Okay. Lactic acid mesh. Anything that has mesh, I'm walking away. Okay. Okay. Tenting screws, I'm okay with. All right. Bulking and putting membranes on top, I'm okay with. Can you use BMPs in those cases? Yes. Okay. So bioactive modifiers, you can take them. Can I ask you all a question and I want an honest answer? Okay, I'm going to poll you all. What kind of sinus lift is harder? Free end or one tooth?
One, two,
Harder or easier?
harder.
Do you all agree? Do you have different? Why?
The space is more.
Space is a lot smaller, right? You all agree? What do you think? Free end is better. Yeah. Now, let's look at a different aspect. When you do one tooth sinus lift, how much bone are you exposing? Okay, so you're not exposing a lot of bone. So technically it could be harder. Okay, but if you raise a big flap, it's still not hard. Okay, if you raise a big flap, it's still not hard. If you use a membrane, it's not hard. But the amount of bone that you're exposing is less. So the regenerative ability for the graft is reduced. As a matter of fact, they recommend using BMPs for single sites, not as much for larger sites. For larger sites, you have bone. You can drop a little bit of Gem 20 watch, which is not as expensive. It's $200 a bottle. Okay. But for a single site, BMP may be needed. Okay. So the smaller the area, the more help you need. Here's a case. One tooth. By the way, I find these very hard too. And I try to find any reason to do a crestal lift in those cases. I'm gonna do Versa. I'm gonna do the pump. I'll try whatever to avoid a lateral in this area. Because I got root, it's a tight spot. Okay. But here, flap, window, smooth the window. Here's the BMP. Okay, see it? Do you see the sinus membrane? You see the perf? over the, is it the premolar or molar? I don't know. You see the perf? You see the membrane closing the perf? And then we we mix the bone with the Chem 21. And here we are. Zero complications to adjacent teeth in tight spots. Don't be afraid. Okay? Zero complications to adjacent teeth in tight spots. Right? You open the window, lift the membrane, you're not going to affect the teeth at all. Okay? Use BMP. You see the sides of the bone here. And let me show you before and after. One on the right and one on the left. You see the amount of bone? I mean, compared to the amount of bone exposed, the volume of bone added is tremendous. Okay? So that's why the BMPs were needed in this case. These are some of the cases where you need to think, do I need my little helper or no? Okay? You get it, you add it to the bone, you add it to the cost, and explain that to the patient. Any questions about lateral sinus lift? I mean, does it seem easy? Does it seem easy? Okay. What's the hard part? What's hard? The flap? Okay, you tear the membrane. Which membrane are you talking about? Oh, the collagen membrane. Okay, you do a couple of them, you get it. Right? What's hard? What were we afraid of? Okay, we dealt with that. Perforation. We're putting a membrane. So you put the membrane. What kind of membrane are we replacing? Bovine cross-linked. You get the 30 by 40. Okay. And you're gonna cut it, trim it, put it in, tack it on the outside, put your bone in. Okay. Take your time. No rush. You're not a better dentist if you do it fast. Okay. Take your time. Speed will come as you build your process. Okay. Speed will come as you build your process. He's like, yeah, I remember this. I remember I can numb. Oh, I can cut. I can reflect. I can open the window. I've done this 1, 2, 3. By the third time, it will be really easy because technically it is not a hard thing to do. Once you do it once, it's very easy. You've done a few. Is it hard? It's not hard. You lift, you raise, you open. It's there. You get it. Okay. It's everything around it that matters. Okay. It's everything around it that matters. The devil's in the detail. So Crestal approach is easier. Crestal approach is safer. I'm going to do Crestal. And with Versa, I've eliminated 80% of lateral sinus lifts in my practice. Okay. Do you really want me to go over historical sinus, Crestal lift? You make a little hole, you tap it, you open it. It's like as if you're coming down from the sewage and you're lifting the lid open. Okay, that's the analogy I like to use. Okay, you're lifting this open and you're looking around and then you start backing the bone. Okay, do you guarantee that you had no perforation in the area doing it that way? Do you know for sure? I have no idea. It's a blind process. Okay, you're packing, but you never know if it can be to the side. Okay. Okay.
So should we put a membrane all the time?
Huh?
Should you put a membrane all the time before you?
Okay. Imagine this scenario. 10 people. All right. Imagine this scenario. 10 people, they all have appendicitis and they are all rushed to the hospital and they all get appendectomy. Okay. Using the microscopes, you know, they're what is called the endoscopes, laparoscope. So we're using the laparoscope. So 9 of them wake up with, you know, like 3, 4 holes in their stomach, you know, and they know, okay, a laparoscope, fine. One guy wakes up and there's like a cut that big, neatly closed and clean, the lower right quad of his abdomen. Okay. What happened? What happened? The other 9, the surgery went without complications. They went in, they suctioned, they found it, they cut it, they suture. The 10th one, okay, which is your crestal approach, you go in, there is a bleed, it ruptured. What do you do? What if you had not trained for lateral window? What if that surgeon never trained to do appendectomy using the traditional route? That patient would be in a, you know, a whole different ward right now, right? Place a lot colder. So don't ever start crestal without knowing lateral. That's the point I want to drive. You must know lateral in order to do crestal. Okay. Imagine the pilot that you're, you know, flying with got trained on autopilot only. Okay. You can't, I mean, can you trust a pilot who flies only autopilot? Well, if things go wrong, how is that guy gonna land or maneuver? Okay, so you must know lateral. You know lateral, then you can graduate to crestal. You don't do crestal and graduate to lateral. Cool? That's the point. All right. Huh?
Start with cluster and then do local.
Well, to get the feeling for certain cases, to get the feeling for something, okay, but not to. I would like to, I proudly announce that I never used any of these for sinus lifts before, and I never will. Okay, they're a doctor.
Yeah, I have to do it.
Hammering, yeah? I don't know. How do you know you did not, how, I mean, it looks beautiful on a picture, okay? But in a patient's mouth, I don't know. You drill and you stop 2 millimeters short, and then you put the osteotome and you tap and you tap and you tap. And I mean, you got what are you waiting for? What are you going to achieve? Okay. Okay. Now there is another way, okay, to do it. So what they do is they not this one, not this one. I want to show you another one. Okay. There are so many techniques, modified osteom techniques, drills with osteo. So you do the drill and then you do the osteotome, or you do the osteotome only. This one, you put a trifine and then you push it with the osteotome. I really don't want to waste your time and my time and your time over it. But there's a technique, I think you will get a kick out of it, okay? These are x-rays of that case where they're taking the trifine, and you see they're stopping short of the floor, and then they're using the osteotome, and then they're pushing that piece of bone. I think Versa really did a great job, you know, taking away all this stuff, you know, because you can achieve all this using Versa. And then of course the kit. Now a doctor came up with a kit and all that, but instead of doing that, can I suggest we do this? Okay. This is very kind, very easy. Okay. You cut, and in this case we're using Versa. We're doing our osteotomy. And can you see the membrane? I mean, we take the photo. If it's black, if there's a black hole in there, then there's a perf. And yet I cannot guarantee you that we didn't perf here. Okay. And then you take the this is sterile saline. and we're pushing about half cc. Look at this photo right here. We're at 1.5. We're pushing to a half. Okay, and then here we are. So just half cc. And this thing is in the osteotomy, and your partner, your assistant is holding it firmly in place. You've all done this before, most of you have. And then you withdraw, and you just want to make sure that you're back to 1.5 cc again, so you know that you didn't perf. You finish your osteotomy using Versa. You sink 1 millimeter or more. You place your implant, and here we are, 1 to 2 millimeters below. And here's another one. Okay, and another one. Very nice and easy and gentle. Okay, put your PRF. And here was the plan, and here was the execution. There it is. No, but again, we didn't trace much, maybe 4 or 5 millimeters, okay? We put bone.
Not introducing bone.
We did put bone.
We did.
Yeah, we did put bone. We used bone using Versa.
Oh.
Okay, and here it is. Nice bumps. And I think we did I think I did the restoration for her already. She was done in the program too. Crestal bone repositioned trap. I like how they come up with those names. I want to show you this. The other ones I flew through quickly because I'm not going to teach it, and I don't think they're useful. I think first I took away a lot of those old techniques, but this one is good for a reason. Because I think the dentist who came up with it was very, very bored and very, very rich, didn't have to work for a living. So he's not making a window laterally. He's making a window on the crest. Are you all following? Okay. And then he's pushing the bone apically. And that is going to be the roof of the sinus. I can number one, technically it's very hard. You're pushing, you're not pushing a round spot, you're pushing a whole plate. And you're opening a trap into the sinus. So it's going up, and then you're putting the bone, then you're putting the implants back. You're sacrificing good alveolar bone, on the crest, putting it in the sinus. And how can you guarantee that you're not gonna get a tear? Why not if you're doing a window, why not do the lateral and get it over with? So I got a kick out of that one. I want to try it just to see if this is even. How many did he try and how many failed in order for him to post one? I don't know. Okay. Graftless approach. Can you place an implant in a sinus without putting any bone? Yes. What are the parameters? You have 8 millimeters alveolar bone height, okay, or 7, okay, and you're using Versa. You place a 10 millimeter implant and you sink it a millimeter or so below the crest, and it sticks out in the sinus. No problem. You don't need to put bone. You're not sure if there's a perf or not. You're absolutely fine. Let's say you perf. You put the implant in the sinus. Absolutely fine. The sinus is not going to get infected. The implant is not going to get infected. And these are the studies that I'm including right here, okay? Implant success rate related to RBH, which is remaining bone height following crestal techniques, okay? All these studies are there. Conclusion, okay? No difference. If you have enough crestal bone height. You put your implant, whether you lift the membrane or whether you pierce the membrane, sinus is not going to be affected, okay? Implant is not going to be affected. Provided the implant didn't fall in the floor of the mouth, you picked it up and put it back in the sinus, okay? Just say, okay? Keep everything sterile, guys. All right. So, in short, these are all the different crestal techniques. What are they trying to avoid? They're trying to avoid the lateral window, okay? And here's the Miyambe, okay? This is not a tribe in Africa. This is an actual technique, really, in crestal sinus lift. You get a balloon, use it only once. Remember, it has to be sterile, okay? It works, it's good, okay? But it's about $150 to $200 just for the balloon, disposable, and the bone and everything. So what are we saying? What are we saying? Use the time to learn your lateral approach technique. Get good at it. Get good at doing the flat, designing it, looking at the CT, looking at the osteomeatal complex, okay, doing the flap, reflecting the flap. Once you see, that's half the battle. Designing your window, opening your window. Trust me, Dr. Yu, once you open your first window, you're gonna get addicted. It's easy. It's easy. Okay. What do you guys see?
Old lady.
Who sees a young lady?
Oh.
I see a young lady. I'm trying hard to see the old lady. No, seriously. I see this is
Yeah,
the
the
young
youthful-
lady with the
Yeah,
profile.
the youthful soul.
Where is the old lady?
It's in there, it's in there.
But wait, like, show me. I want to find her.
Oh.
Where's the
So you cover this one. Right, you see the chin, the mouth, the nose. And the eye right here. This is the hand.
Oh, yeah. I've that's her mouth right here.
Yeah.
No. I always fail to see that. You can see it now, okay.
The studies say usually we see what we thinking of. So if you see the old lady, that means you're getting old. And if you see the young lady, yes, good for you. Yes, good for you. Young lady, your soul is young. Yes, good for you.
So this is really a paradigm shift. And now that you all have used Versa, using Versa regularly?
I don't have it as using a course.
Okay. It's it will change the way you do things. It really will. Okay. It will increase the initial stability. It will increase the bone concentration, especially in areas of Kinsella's bone, okay? I want to go through the drilling protocol, okay? And I want to be very, very clear. You can use Versa for cutting, just like you use any other kit. So if a doctor wants to switch their implant system and they ask, do I need to buy the kit? I'm thinking, no, you don't, okay? You are going to shape your osteotomy to fit the implant. The kit doesn't matter. You can buy a kit for other reasons, but it's not, you're going to pay. So the Densa, they can fit anything, okay? They have multiple diameters on the top, on the bottom, and in the middle. Some of them come down straight, some of them are tapered, okay? So you're placing a tapered implant, you use the tapered ones, you use the straight ones, you use the straight ones, okay? And I usually use the first two burrs, the first two ones to do my initial osteotomy. The first one is very thin. It's what, 1.2 or 1.6, just to get my bearing. The second one is the 2.0. And after that, it's all in reverse. Your speed has to be between 1200 to, 850 to 1200. You can go up to 1500, okay? You're absolutely fine to go 1500. Lots of water. And as you're drilling, you don't want to push the drill and wait. It's like counting 1, 2, 3, 1, 2, 3. The 2, 3 is out the socket. The 1 is in the socket. The 2, 3 is you're letting the bone cool, recoil, and the water to go in. 1, 2, 3, 1, 2, 3, 1, 2, 3. Let it. That's the way you don't burnish the bone into oblivion. Okay. You want the bone to be nice and fresh, and you want to give it time to cool and to rebound. Okay. And it has the way it's designed, it gives you this haptic feedback. So as you're approaching the sinus, it goes like you feel it, okay? And once you feel it, once you get that feeling, you never forget it. It's there. And once you hit that crestal bone on the sinus, you know. And once you do it once, you'll never forget it again. Okay? And you take your time. So that's how you drill. 1500, lots of water, let the bone cool. And now, if you access the sinus and you put a little piece of membrane in there and you want to pack a bone, you take your bone, put it in the osteotomy using your hand instrument, and then you take your drill, you drop down to 150 speed, 100 to 150, no water, still in reverse. And then you're going to push that bone into the sinus. Okay, so if you drilled all the way to 13, your initial will probably be like, when you go in now, you're pushing bone, maybe a little shy of 13. If you put more bone, you're going to be maybe 11, 12. So don't push the bone and rupture the membrane, okay? You're filling the area, so there's less space for the drill to go through. That's it. And you will find that you will do this crestal sinus lift very easily. You know those principles, you can use Versa. Drop the speed, go in reverse. When you pack the bone, no water. When you're going forward, lots of water, high speed, and keep the instrument outside as long as possible to allow the bone to cool.
How do you break into the crestal floor of the sinus?
By repetition and being very patient. So once you hit the crestal bone, it will vibrate and you just keep coming back to it. And then you don't want to break through it before size 3. Their numbers have changed. When I first took the course with Dr. Huways, it was 4. He said, don't go through the sinus before you reach number 4 diameter. Okay? Now they're saying it's okay to go to number 3. So 3 is the thinnest diameter that you can use once you start breaching the crestal membrane, the crestal sinus fluid. Okay? And you just keep on until you feel it give away, and it will kind of like, and then it will push through. Okay?
In the reverse with water.
Always reverse. But when you put the bone, turn the water off and drop down to 100, between 50 to 150. Okay?
And now you're adding the bone in the very last phase.
Very last.
Very last.
After I'm done with my osteotomy and everything.
Just before we-
Yes. Yes. Okay.
Have you, I'm sorry, use Versa on a class 2 bone,
Uh,
or you always use it on a 4? 3 or 4?
3 or 4.
There's no need to use the 2. as it is,
No, 2, no. 3 or 4.
I used Versa on 1819 and 18
Use Versa 1819,
Yeah,
18.
18 Like saying that
Do you think the bone was overheated? Yeah. Why did you use Versa?
this is like why did I use it?
Oh,
Actually,
was it grafted?
No. So that was a mistake, but I learned to. Yeah, I placed both of them, came back, everything's fine, and then noticed something on 18, that seems like it's not taking it out.
Yeah.
On the cortical blades.
Yes.
actually go down.
Yes.
So I
Yes.
bring it back again, and I feel that it's not taking it, so I remove the implant and bone graft. And bring it back up, that's it again, there's not in a new version, I just, put real there.
Yes, yes. And that's why you want to have the regular kit. Okay, so what you could have done, you could have taken taken the implant out, taken your regular kit and run it once to get fresh bone and then put a 6. Yeah, yeah, yeah. And then put a 6. Oh, got it. Got it. Okay, very interesting. Bone actually is very kind to work with. You know, he's very kind to us. Bone is the way it's almost elastic. You know, you can move bone, you know, and it grows and it so healing the bone is actually one of the positives that we have when we're doing implant dentistry. Just don't abuse it. You know, you abuse it too much, it's going to walk out on you. And when it does, it's not a good day. No amount of counseling will bring it back. Traditional bone drills. These are the traditional bone drills. They take away bone and they are never exactly centric. Okay. The osteotomy, once it's done, it's not, but using the densa burrs, the versa burrs, you will always get a nice concentric osteotomy. And remember, once you build your path and you have your you know your depth, you know your angle and everything, the rest you're not guiding your drill. You've already built the pathway and the drill is going fast in reverse, and what it's doing, it's going in the same set path and it's just pushing things sideways. So the chances of veering away from your initial osteotomy are a lot less. And then look at the bone. Look at the bone here using the regular drills. You lose all your bone. You place your implant, you lost all the buccal plate. Now you have to do a whole lot of grafting. You do that grafting, how much of it is going to stay, how much will persevere over the years, we don't know. Okay, so the haptic feedback. Okay, the haptic feedback is one of the things that you feel in the drill. You don't feel that with the regular drills. Okay, the compressive waves, it osteodensifies apically and sideways. You all know that, we talked about it. And here's when you do a cutting mode, look at this. The cut is very nice and very concentric. Okay, and then here's a tibia, and look at the standard drill for the first one on the left. Look at the extraction drilling where you're actually taking away bone, and look at the osteodensification one. Okay, so you get more bone to implant contact, BIC, with this. This is a study from Dr. Paolo Tracy from Italy. He goes through he does the study for you. If you guys, I included it in the lectures if you want to go in there and pull it out and read it. There's the purpose, the results, okay, and the conclusion. And the osseodensification technique increase primary stability and bone mineral density and percentage of bone at the implant surface compared to regular drilling. So it's just saying it's all good. Increased when you're doing a fresh site of extraction, like a number 19, for instance, and you're taking out number 19 and you're placing an implant, you don't have a lot of bone to work with. You're doing your osteotomy in the interradicular bone, right? Can you imagine what happens when you use the regular drills? You're gonna eat it away. When you use the burrs, it's going to push everything sideways, and you can actually place an implant at the site of a fresh extraction site with very, very good degree of stability as well. Okay. So I don't get paid by Verso. I don't work for them, but I've used them and I really, really like the results that we get out of them. Why am I talking about Versa with regards to sinus lifts? Because in the cases where you're going to place the implant as you do the lift, it's much better to use the Versa because you're keeping as much bone as possible in the area and increasing the primary stability. Let's go through some cases here very quickly. These are cases that had sinus lifts using the membrane. We tack the collagen membrane cross-linked, okay? It's xenograft and allograft, 50-50 mix. And then they took a sample of bone, okay? And here's the histological sample of it, okay? All that pink stuff, and these are the aversion systems, right? This is bone, okay? These are the matrix. That's the matrix from the xenograft, okay? So very, very good dense bone, okay? So I'm convinced I can use xenograft in the sinus lift and the results will come out good, okay? Here's a 20-year slide. This is not mine, okay? Look at the tissues, look at the implants, okay? Okay. 20 years. I mean, these are very long implants. He's saying something here I really want us to hear, and I'm really bothered by the fact that that we're not able to hear it. Okay, I will tell you what he's saying. Saying people talk about, hey, I can do a sinus lift in 30 minutes, I can do it in 45 minutes, I can do it in an hour, and you're sitting here and thinking it takes me 2 hours. I have to clear a morning to do a sinus lift. You know, what's wrong with me? Don't think like that. Okay. Maybe you clear the morning to do a sinus lift, the first few ones. Okay. And then after that, it will be just 2 hours, and then you'll book an hour and a half, and you may start double booking somebody else towards the last half or whatever it is. Okay. Personally, I book 2 hours and I don't want to be double booked. I don't want to be bothered. Okay. I want to be prepared for the eventuality, whatever happens. Okay. What if? And now the stress is coming up. Okay. I got hygiene recall. I got another patient. Mr. Jones is here because I'm delivering the crown after I changed the color that he didn't like the last time, and he's leaving town after the weekend and all that stuff. Take your time, go through the process. Have it written down before you start, okay? I looked through the CT. I went through the medical history. There's no history of chronic sinusitis. Okay, I know the osteomeatal complex, the OMC is clear. I can see There is no pathology, or if there is, there's a little bit of thickening in the membrane. I know I'm going to open right above tooth number 5, and I'm going to be 7 millimeters above the ridge once I remove my thing. And I'm going to go 8 or 10 millimeters, and I'm going to cut. I'm going to have my Elman unit right next to me, ready with the clamps. That bugger starts bleeding, I'm going to clamp it, and I'm going to stop the bleeding, and I'm going to push the membrane, and I'm going to suture the top of the membrane to my vaccinator muscle, maybe even the back. This way, my assistant has less work to do. I'm going to open the window. I'm not going to use the piezo. I'm going to use the round diamond. I open it. I'm not going to throw it away. I'm going to make it part of my bone graft. Okay, is my membrane here? Are my tacks here? Okay, lift the membrane. I lift the membrane and I get a little tear. Do I abort? Do I get terrified? Do I go call code brown? No, I just proceed. Oh, well, it happens. I was expecting it to happen. I'm going to treat it like it's already happening anyways. You lift the membrane. Okay, you cut your collagen membrane, try it in a couple of times. You do a little groove above the window, you tack it, okay? Now we start packing the bone. Pack the bone, pack the bone, pack the bone. Are you placing implant? You do your osteotomy. You're not placing implant, you don't do the osteotomy. Close it, and then what do we want to do for the window? We want to make sure we close it because there's going to be expansion. And how many of the cases? 100% of the cases. You put your membrane, couple more tacks, maybe one on the pathol, suture, start with your mesial, close it, interrupted, or I mean mattress, continuous interlocking mattress. Don't forget to close the back, sit them back up, easy, go through the post-op instructions. So you're gonna bruise, gonna do this, this. I wanna see you in a week. Should you get nosebleeds, whatever, you let me know right away. We don't expect anything. If you feel particles in your mouth, that's normal. If you wake up with a little bit of blood in your mouth, that's okay. Okay, here's my number. Call me, text me, send me photos or whatever. If you want to show me I'm swollen, here's how much. Yeah, that's normal, or no, let me go to the office in the middle of the night kind of thing. Okay, that's it. You go through it one time after the other, and it becomes normal routine. Your assistant will learn. Here's the kit, it's got everything, and here's the bone tack system. Here's this for the control, and here are the membranes in the fridge. Are we ready or not? You do it, and that's it. Okay, single tooth.
Why would they get mostly?
Remember, it's a highly vascular area, right? And the infraorbital has 1 intraosseous and 3 extraosseous. And the posterior superior has, or the opposite, or PSA has 1 extraosseous and 3 intra and 1 ex, and from the sphenopalatine and from the lateral. So you get a lot of bone, and you're lifting the membrane, and the membrane is got some vessels to it. So you rupture some venules here and there, okay? And they lean back, and the blood, and then remember the cilia are just working here, they're just gonna come out. Okay.
It's
So
not, it's okay.
it's okay if they, but not gushing. Okay, if they're gushing, you will find out during surgery, you did something during the surgery if it's gushing, but it shouldn't be. Okay. You all get the picture? Single tooth is a harder approach, and it doesn't have a lot of bone around it. So what do we do with the single one? We use the bazooka. We bring in the BMP. Okay, we just we use the chemical to try and get the those osteoblasts to come to the site. Okay, and most of the times you'll get a very, very good, reasonable, stable result. Okay, again, if you only know how to do crestal, okay, when things go south, you're stuck. and you're gonna be calling the oral surgeon or somebody, and you're gonna be, what, I'll pay you whatever, just, but no reason to freak out. Okay, no reason to freak out at all. Okay. Raise your flap, make it a big flap. The fact that you're doing a sinus lift around one tooth doesn't mean that you can only raise the flap over that one tooth. Okay. Go back, raise a big flap in the back, open the window, remove. Look at the adjacent teeth, look at the membrane. If it tears, okay. After it tears, what you do? You put the membrane, which you're planning on putting in anyways, okay? Pack your bone and close. Remember, you close your mesial, and here you are. So these are the cases. One more time. Okay, I'm gonna do something really mean here. I'm going to ask one of you at random to come up here and go through the process. Do I get volunteers or do I get to pick on my own?
Should I volunteer somebody?
Any volunteers? Dr. Yu. Yeah.
Yeah.
Let's just go through the process. Tell me.
It doesn't matter.
So we're doing a sinus lift.
So you, obviously, your CT scans, your anatomy, you do your incision, including the patella. Go back to this flap, your window, using there's and then keep that bone. Start lifting the sinus on the
Superior part.
superior, distal, mesial, last inferior.
Okay.
That's the hardest.
Okay.
And then your cross-link collagen membrane.
Yes,
Yes, okay, pack it there.
yes.
Then you pack another one toward, except the floor.
We're putting the PRF inside.
Yes, OPR inside.
Yeah.
Your first, did you put two or one? You put the first one and you tack it,
Yes,
But you-
only one
only one.
membrane.
then you make a dent, so
Yes,
it's easier for you to see and tack it.
yes.
So once you do that, which is first, the PRF or the?
Doesn't matter.
Doesn't
I
matter.
would tack it first and then put the PRF next.
The person, so it's not moving, okay, put the PRF toward the. What is that? Medial
Posterior,
posterior,
yes.
okay. And then you put the, after the. Oh, if you're placing implants, you're osteotomy first.
Yes,
If you're not, well, if you, osteotomy and then you place your implants and then you go back.
okay,
Oh, no,
yes,
no, it's right, okay.
And then
if you're not placing implants, you pack the bone with, allograft and xeno.
yes.
Oh, you harvest if you harvested bone.
Yes.
then-
Or the window, you can crush it and put it in there, okay,
Mhm.
good. And are we going to leave the window open or are we going, what are we?
After-
Because what happens in 100% of the case, expansion, okay, good. Can you go through that? Okay? In your mind, okay? All right, I'll let you guys forget a little bit and then we'll come back and I'll get another one. Okay? All right. I want to promote this doctor right here, Dr. Myron. When we did the bone grafting lecture, I had a lot of stuff from his book and I have referenced him at the very end too of that lecture. But if you want to learn anything about the materials and the membranes, and he's got very, very nice pictures. We love pictures, okay? So it's not all writing, but he's got some nice tables too. So if you want to look at the tables and see, okay, I want this kind of bone and this kind of membrane and this and that, but if you want to be very well versed in that arena, this is a very good good book to get. I am taking his course very soon so I can answer questions about LPRF and CGF and RPF, and not that I'm inclined to memorize chemistry and stuff, but I want to see if I can get something that I can apply clinically, okay, and maybe change a few things when we do our routine, and just see if anything will stick in my brain.
I can vouch for him. I took his class.
Oh, you took his class? You went to Florida?
Excellent course. No, he was here in LA, Valley,
Yeah,
2 years back.
Yeah,
Excellent.
yeah, very good.
Not much clinical procedural, but.
It's
he was
mostly,
right
yeah.
there. Very knowledgeable.
He's one of the he's become one of the leading voices
Yes,
in
he
that arena. You see the PRF, you see what it does to the bone. Very, very, very nice. And I'm going to if you don't use it, I'm going to strongly encourage you, to get it. I'll show you where to get the stuff.
Well, he was part of my stepping stone to do it.
Okay.
I was in that course, and the second day we did it on each other.
So
I don't
you
know if that course is what you're taking too.
are you like hands-on?
He had a hand on the second
I
day.
don't know if it's hands-on or not. No, I think this one is just didactic. Are you doing PRF in your office?
No, I'm not.
Why not?
I didn't take this, I don't know. I
Okay.
should have,
Maybe I
In
can
hindsight.
maybe I can convince you.
maybe.
Wait till I show you, and then you'll like, okay, look at this case. What are we doing? We're looking at the floor, right? We're looking at the height, looking at the width, looking at the osteomeatal complex. Okay, I'm going to ask one question. It's a number that I mentioned early on, from the alveolar process to the OMC is what? 40. Okay, all right, good to know. What do you do here? You got good width. The height, do you 4.5 millimeter height? Do I do immediate placement? Yeah, I think maybe. Okay, let's do the flap. Let's open with the window. Here's the window using the piezo. And now I'm lifting the membrane. Nice, it's lifting nicely, lifting nicely. I'm breathing better. I'm starting to whistle. Okay, I'm not mad at my assistant anymore. do you guys do that? It's just like, what did I do? Okay, and oops, what do you see? There. Damn, I blew through another one. Okay, there she goes, bringing the collagen cross-linked membrane. We're cutting it, shaping it, cutting the corners, getting it wet with CGF maybe, doing the dimples around my window so the tacks will not bend. They put them in. Okay. Danger. What danger? And I mix my bone. This is a single site. So what am I going to do? I'm going to bring the heavy hitters, BMP, cut it, mix it with the bone. Yeah. But, huh?
$250 right there.
No, that's probably 650, 800.
No, I mean, like, you know how you got that in 4 pieces?
Oh, yeah, but you're using it just for one patient. You don't get to yeah. Pack the bone. And here's the Ostel reading. It's 73. Yes, Dr. Desai.
Well, why did we do worse in this case? Height was 4.5, so that's what we've done.
Okay. How much height? I forgot to mention this. Huh?
How do you
For
say?
person, how much do you
Is
need?
that the high minimum 5, not a minimum?
Yeah, but how much bone can you get? How much? 3 with Versa. They say 3. Okay. 4. I used to be very, very greedy. I would just go as, you know, if I have 5, I'm going 5, I'm going 6. Okay. But it was really blind. Like I never got confirmation that I did not perf for sure. Okay. And I did have a couple of failures when I did that. I was like, why? I mean, and I looked at the x-ray, I looked at the CT, and I got, it looks like a nice bump and everything, but I don't know. And I usually drop in a PRF. But 4.5 plus 3 is what? 7.5. And if you're going to sink it 1 or 2 millimeters, then what are you placing? Okay. And this is a molar. So you really want a good size implant. So hence the lift.
With the pump, how much we can get?
3, 5 at the most. The pump a little bit more than the Versa. Okay. The pump, because the pump doesn't have the metal point. But because it's a small area, not a lot of bone, we add the BMPs. Okay. And here's the fibrin clot over the window. After we close the window, we're closing the mesial. And we got good initial stability that we added the healing abutment right away. Okay. Now, what happens when we have like 13, 14, or 4 and 5, or 2, you know, multiple spaces between teeth? Okay. How is that going to be any different? It's probably a little easier. Okay. We have a distal tooth behind us. Okay. So here it is. So we open the window. What do we get? A tear. Okay. That's okay. I'm not going to lose my cool. I'm going to get my membrane, make the little trough, wet the membrane in the CGF, put it in the sinus, make sure that I've lifted. I proceed with my lift. I really want to make sure that I got that posterior wall exposed. I want to see that bone, posterior, mesial, apical, maybe put some PRF, and then tack it down, pack the bone, okay, place the implants. I'm placing the implants. If you get good stability, don't worry about it. Put healing abutments and good. So far, what have we covered? We've covered a single tooth, multiple, right? Let's do multiple with distal extension. So the whole quad is gone. How is that going to be any different? We're exposing more bone. Okay, so we're going to extend our window a little bit more distally, right? Okay. Here we are. Exposing, opening the sinus, putting the membrane, doing the osteotomies, putting the implants. And here's the ostal reading, putting the healing abutments. And here's the healing, nice healing. And here's the, and after we're done, here's the osteomeatal complex. Nice and patent and clear. Okay. I don't do these crowns. I do them in very, very specific cases, the PFMs, okay, not always. If I do, I'll do the metal in high noble because I want something that's nice and kind, especially in patients that have occlusal problems. Okay. Same thing. Are your eyes getting used to the surgery? Okay. Getting used to the idea of flapping, window, membrane, bone, in. Look at this. Nice lift. Very nice. And here's another case. Flap, open the window, remove the window, get to the membrane, use the piezo, smooth the edges, and use the piezo to start and lift the membrane. And we're lifting the superior, mesial, distal, and now we're moving down to the inferior part where you're removing off the floor. Okay, and we're using our curettes, and everything is going fine until, and we're like, so what? I can do it. You get the membrane and then you connect everything. All right, it's 3 o'clock. Let's take a 5-minute break. Because after lunch, I know let's take a little